to our East Coast participants, and good afternoon to those who are tuning in on the West Coast. Welcome to our webinar, Understanding Risk Reduction and Treatment Options for Erectile Dysfunction and Other Common Side Effects of Prostate Cancer. It's brought to you by Zero the End of Prostate Cancer. And my name is Jamie Burse. I'm the president and CEO at Zero. And thank you all for joining us today. We have a record-setting number of attendees for tonight's webinar, over 300. So thank you to each and every one of you for participating. Looking at the list, looks like we might have a couple of celebrities like Chad Johnson, who's a former NFL receiver, and maybe even Daryl Hall, the rock star. So we hope that this webinar makes all your dreams come true. Now, before we start, I'd like to go over a few housekeeping items. First, today's call is being recorded and will be archived on Zero's website within the week. You should also receive an email with a copy of the recording. In addition, it is being streamed on Zero's Facebook page. So there's, in addition to the 300 participants, we also have those tuning in on Facebook. So hello, Facebook. The format of today's program will be as follows. I'll do the introductions, and then I will hand the program over to Dr. James Yu for his presentation on space or hydrogel. When he's finished, we'll have a short question and answer period before I hand it over to Dr. Williams for his presentation on life after prostate cancer. Recovery is a journey. To ask a question, please type it in the question box that you see in the webinar user screen to your lower left-hand side. You can ask a question at any time, and at the end of the webinar, we'll go through them and try to answer as many as possible. We have an hour for today's presentation, and we're going to end right around 7:30 p.m. Eastern Time. When you close out of the webinar, you'll be redirected to a really short survey. Please take time and fill that out because your input enables us to be able to provide the most impactful programs for patients and families that we can. Lastly, I want to thank our sponsor of today's program, Boston Scientific, for their great partnership and for their support. And with that, thank you, and let's get started. First up is just to cover a little bit about us at Zero. Our mission is to end prostate cancer. As a leader in the fight against prostate cancer, Zero advances research. We improve the lives of men and families, and we inspire action. Again, tonight's lineup will be Dr. R. Clay Williams and Dr. James Yu. We'll cover space or hydrogel with questions and answers, and then life after prostate cancer, recovery is a journey, followed by your questions and answers for Dr. Williams. First up, on way of bio, I'd like to introduce you to Dr. Williams, who is an East Texas native from Texarkana, Texas. After receiving his undergraduate education from Stephen F. Austin State University, graduated valedictorian from medical school at the University of North Texas Health Science Center in Fort Worth. He then completed 2 years of general surgery and 4 years of urological surgery residency at the University of Arkansas for Medical Sciences in Little Rock, Arkansas. Dr. Williams specializes in both male and female pelvic floor disorders, such as erectile dysfunction, penile prosthetics, female vaginal bladder prolapse, as well as both male and female pelvic incontinence, evaluation, and treatment. Our other speaker tonight is Dr. Yu, Dr. James Yu. James Yu is an MD and MHS, and is the director of Yale Medicine's Prostate and Genitourinary Cancer Radiotherapy Program. A radiation oncologist, Dr. Yu specializes in treating gerontology cancers such as kidney, bladder, and prostate, central nervous system cancers, cases requiring gamma knife stereotactical radiosurgery. And as a professor of therapeutic radiology at the Yale School of Medicine, Dr. Yu also conducts research on ways to use radiotherapy treatments to improve outcomes for cancer patients. As a former Yale Center for Clinical Investigation scholar and member of the Center Outcomes in Public Policy and Effectiveness Research, or COPPER for short, Center at Yale. Dr. Yu's research centers on comparative effectiveness of new radiation technologies and how these new technologies are adapted nationally. Dr. Yu is essentially a senior editor of the journal Practical Radiation Oncology and is on the editorial board of the Journal of Clinical Oncology, Journal of Clinical Oncology, Clinical Cancer Informatics, JNCI, and JNCI Cancer Spectrum, European Urology Oncology, Journal of Surgical Oncology, and Oncology at Wilson Park. Dr. Yu, that's a very impressive resume. Thank you for being able to have the time to join us tonight to be able to talk about space war. I was just talking to a patient this week, actually a patient doctor this week, who had said that that they were so thankful for the use of space war that it was able to spare him completely from any kind of side effect that happened as a result of treating prostate cancer with radiation. So I'm excited to hear what you have to share with us. So thank you for joining us, Dr. Yu. I'll turn it over to you.
Great. Thank you, Jamie. I really appreciate it. And if I had known you were going to read that whole thing, I would have made it much shorter. So it's very kind of you, very kind of Zero Prostate Cancer to invite me to talk. I'm very excited. And also, I want to welcome all of the people who are on this call and listening in on Facebook, wherever you are. Kudos to you for learning more about prostate cancer. If you have prostate cancer, you've been diagnosed with it, or a loved one, there's nothing more powerful than education and learning about what your options are. So kudos to all of you. As the first speaker, it's my role to be on time, so we're going to get going. I'm going to divide this talk into 4 basic parts. I'm going to try and get done in about 10 to 15 minutes to leave some time for questions afterwards, but I'm going to do a basic overview of prostate cancer in terms of the statistics. What is it? How do you diagnose it? What are the general treatment options? Then I'm going to talk about radiation treatment, mainly concentrating on the most common form of radiation treatment, which is external beam radiation therapy. And I'm going to talk about the side effects and problems that still remain even with the most modern radiotherapy treatments. Finally, I'm going to talk about what space or hydrogel is. This is the product that Jamie kind of foreshadowed. And Boston Scientific is the sponsor of this talk. But I'm going to talk about the scientific rationale behind space or hydrogel and the clinical results to date, which are quite exciting. And I can see the questions that are being posted. Keep them coming. We'll try and get to them as we go through this talk. But prostate cancer is extremely common. It's the most common solid tumor in men. About 1 man in 9 will be diagnosed with prostate cancer during his lifetime. And about 1 man in 41 will die of prostate cancer in the United States. So there's a big difference between 1 in 9 and 1 in 41, right? So one of the things that has been said about prostate cancer is it's generally not a deadly cancer, in the sense that the 5-year survival is about 99%, and the 10-year survival is about 98%. What that doesn't say, though, is that in these hundreds of thousands of men who do get prostate cancer, there is still a significant minority of patients who are developing deadly disease. And so a lot of research is centering around trying to cure those patients with the highest risk prostate cancer. But for the patients who have a more favorable kind of prostate cancer, much research has actually been focused, well, we do a great job curing these patients. What about their long-term quality of life? And I think that's what we're here to talk about today. So the joke about politics, all politics is local. For radiation, all side effects are local, meaning that because of the anatomy of the prostate, where the prostate sits, radiating that prostate will cause side effects because of what's next to it. So if you can see this screen, you see the prostate sits in between the bladder and the urethra, which is the tube that runs out of the prostate to the bottom. The urethra actually runs right through the prostate. And then immediately behind the prostate is the rectum. This is why when you have a digital rectal exam, you can actually feel through the thin rectal wall to feel the back of the prostate. You can feel nodules in it. The rectum is right up against the prostate. And sorry, going back, not pictured in this slide are also those neurovascular bundles of nerves and blood vessels that travel around the prostate and supply the penis for erections. And so erectile dysfunction can occur with any sort of manipulation, either with radiation or surgically, of those neurovascular bundles. So once again, all the side effects associated with prostate radiation are right there due to the anatomy. How do we diagnose prostate cancer? Well, typically it's by screening. The most common screening methods are what's called a PSA, prostate-specific antigen, otherwise known as the blood test. If you have an elevated PSA beyond what is typically seen in the standard U.S. population, you will be sent for a a biopsy after a discussion with your urologist or your primary care provider. Another way to detect prostate cancer is by digital rectal exam. We've talked about that. Unfortunately, a lot of times patients are diagnosed when they start to have pain or discomfort. And we don't like to diagnose prostate cancer this way because it typically means the cancer has spread to the point of not being easily cured. How does that biopsy work? Well, on the left side, you can do what's called a transrectal biopsy, where an ultrasound probe is inserted into the rectum and a biopsy, that's on the right, and the biopsy needle is put in through the rectal wall into the prostate. Or you can have what's called a transperineal approach, where a needle goes in not through the rectum, but the needle goes in through the perineum, which is that space between the rectum and the testicles. An ultrasound probe is still needed in the rectum, though, to visualize where the prostate is. So how do we stratify prostate cancer into severities? Well, the three pillars are Gleason score, otherwise known as gray group, which is what the prostate cancer looks like under the microscope. You can you add to that the PSA blood test, which tells you somewhat what the burden of tumor is in your body, and then the third part is the T stage, which is how big is the tumor on clinical exam, and increasingly also incorporating imaging. And then there's all sorts of other factors that you may have heard about. PSA velocity, which is how fast the PSA is going up. Genomic testing is becoming more standard, where the gene profiles of the tumor are sent, and those with more metastatic potential are potentially at increased risk for causing metastases. The volume of the tumor, the number of cores positive, the presence of something called perineural invasion. There's all sorts of other factors that add information. But again, the three pillars are the Gleason score, T stage, and PSA. We take those three pillars plus the other information, and it goes into a discussion about which treatment is the best option for you. Now, I know Dr. Williams is going to talk after me, so I'm not going to talk about surgery versus radiation because he'll have the last word on that. I will say that there are options on both sides. For radiation therapy, there's the placement of radioactive seeds or catheters that can transmit radioactivity remotely via a radioactive seed that's placed temporarily inside the catheter. These are called low-dose rate and high-dose rate brachytherapy. There's different forms of teletherapy or beamed radiation, 3D conformal, IMRT, SBRT, and there's also proton therapy, which we'll talk about very briefly. I'll leave the surgery stuff to Dr. Williams, but there's also active surveillance, which is neither surgery nor radiation, but rather just watching your prostate cancer. And this is often an appropriate thing to do when you have a low-risk prostate cancer that's unlikely to cause you problems within your lifetime. All of these, however, have risks and side effects. Even active surveillance sometimes has side effects if that active surveillance involves repeated biopsies, for example, which I believe active surveillance should involve. So that's prostate cancer in a nutshell. We had a question from Sonia. Is prostate cancer not known to metastasize, but are you seeing more cases of this? So yes, prostate cancer is known to metastasize in some cases. Recent evaluation of the NCI SEER database has noted there is an increase in metastatic prostate cancer over the past couple years. We hypothesize it may be due to decreased screening that began years ago. And so the idea is that these early cases of prostate cancer aren't being found and patients are presenting later with metastatic disease. Now, correlation is not causation. It could be that there's something else besides a lower rate of screening causing increased metastatic disease. But for what it's worth, we are seeing more cases of metastatic disease. So radiation in a nutshell, there's many different types of radiation. Radiation's all around us, cosmic beams, neutrinos, all that stuff. Therapeutic radiation, though, typically is photons, but you can also have particle therapy as well, electrons, protons, neutrons, alpha particles, heavy ions or carbon ions, but the main workhorse is photon beam radiation. How does radiation kill cancer? This was pretty mysterious, I think, but the radiation breaks the DNA of a cancer cell or causes DNA damage of the cancer cell. Cancer cells can't repair that DNA damage as well, and a cell without viable DNA cannot divide. That's essentially radiation biology in 30 seconds. The idea is that normal tissue has a better DNA repair mechanism than the cancer cell. And so that's, again, the mechanism behind radiation causing cancer to die. Now, damaging the DNA of normal cells is also not good. And oftentimes fast-growing tissue, like the mucosa of your rectum, for example, also gets damaged by radiation. And so there is toxicity when you radiate normal tissue. So what is intensity modulated radiation therapy? So we talked about photons being the workhorse of radiation. Intensity modulated radiation is photon beams that are not kind of like a spotlight, but rather having shades within that spotlight. It's not a uniform beam, but the intensity of the beam is modulated across it. And so you have shadows and bright spots. If you incorporate all of these shadows and bright spots together, you can create a very complicated treatment that will conform to your target better, in this case, the prostate. And studies have suggested that IMRT is superior to the standard 3D conformal radiation in protecting the rectum. You can't hit what you don't see, and so we've also developed something called image-guided radiation therapy, where every treatment, we image your body in 3D space, and we find exactly where the prostate is, because your prostate can move, believe it or not. If you have a full rectum, for example, versus an empty rectum, that can shift the position of your prostate up and down. And again, not to belabor the point, but all of the stuff around the prostate is what causes the side effects. The bladder's right on top of the prostate, the urethra running right through it, the penile bulb, which is part of the erectile tissue of the penis, is inferior to the prostate, meaning below the prostate. And it's theorized that over-radiating the penile bulb can cause erectile dysfunction in the long term. The anal sphincter is right there, and the rectum. All of these things, obviously important structures for bowel movements. And you can see on the left, this high dose region in red and kind of this moderate dose region in green it's all up into the rectum. And if you can't push the rectum away, you're necessarily radiating it because it's right up against the prostate, and you don't want to miss the cancer. So are there side effects from prostate radiotherapy? I think the answer is yes. Sad to say, but we do cause side effects. And if you go and see a billboard on the side of the highway saying no side effects from radiation treatment, I don't know how they do that. They're probably bending time and space. But you saw that the rectum is right behind the prostate. Randomized studies are typically the gold standard of measuring side effects, and these are examples of 4 randomized studies that have occurred. These are the control arms of the randomized study, meaning this is the standard, gold standard treatment that occurred on these very kind of high surveillance, very strict randomized studies, and there were still anywhere from 13 to 24% grade 2 and higher GI toxicity. What grade 2 or higher means is that it was a side effect that was bothersome to the point where it needed some sort of medical attention, or it was just so bothersome that it was more than just a little bit. It's hard to explain, but for example, if you were having 6 bowel movements a day, that's a grade 2 toxicity. Or if you had a little blood in your rectum in a bowel movement, that's a grade 2 toxicity. Grade 3 toxicity would be something that's major, like if you needed a laser thermocoagulation of a bleeding area in your rectum, for example, or if you needed like a narcotic pain medication, that's a grade 3 toxicity. So this is indicating a 13 to 25% grade 2 or higher toxicity seen even in the strictest of studies. And again, it's because the rectum is right behind the prostate. You can't avoid it. You have to treat the prostate with a little margin. If you just treat the prostate without adding in an error margin, you're going to miss the prostate if the patient has a different prostate position or moves a little bit. So in radiation oncology, we always add a little bit of a margin. Because the rectum's right up against the prostate, that means without some space there, you're intentionally radiating the prostate. And the rectum is thought to be what's called an organ at risk. That's what the OAR comes from. You over-radiate the rectum, you can get bleeding, frequent bowel movements, urgency, but devastating side effects such as the fistula, for example, which is a hole or a connection. Rectal side effects, I don't need to tell those men on the call, can be very, very significant to your quality of life. So it's not just a suck it up kind of thing. These are major problems that ideally we would prevent all of them. So what is hydrogel? It's actually very, very simple. It pushes the rectum away from the prostate. It tries to minimize rectal wall radiation exposure, and then it turns back into a liquid and is absorbed into the body. It's made of water and polyethylene glycol. This stuff you can kind of inject almost anywhere in the body. You've probably already ingested it at one point in your life if you've taken medications or used artificial tears, etc. So it's a very safe substance. And the proof is in the pudding. Clinical results have shown that in a randomized study by Dr. Hamstra, that spacer reduces rectal complications. It also reduces urinary complications, which I think was surprising to everybody. It's always nice when there's a positive outcome that you didn't expect out of the study. Probably because if you're going to the bowel, if you're having a bowel movement 6 times a day, you're probably urinating 6 times a day as well. And so fewer urinary complications as well with a spacer and better quality of life. There's been over 75 peer-reviewed publications. Part of my excessively long bio were the journal editorships that I have. So I do like to evaluate data, and SpaceOR to me is something that has a lot of data behind it. So I'm happy to recommend it to patients over 50,000 patients treated worldwide, and it is used in many of the leading cancer centers in the United States. This has been really embraced by academic physicians and by physicians not in academic practice. And it's also reimbursed by Medicare and a growing number of private insurance companies because they realize this is cost effective. So once again, thank you very much for inviting me. I think it's almost 7 o'clock. I can probably answer a couple questions at this point. Let's see. Do biopsies for cancer? Go ahead. Sorry.
Oh, no, I was just going to tee them up for you. So could you restate? I know you just covered this in the last slide, but we do have a question about is SpaceOAR hydrogel covered by Medicare? And they added in, is it useful for someone who's already undergone treatment?
Yeah, so that's a great question. Right now, there's no proof, no strong proof in my eyes that it's essential for somebody who's already undergone treatment. Now, it is, in very simple terms, something that pushes one thing away from the other. So theoretically, if you have a tumor that you can push away from the rectum, even if you've had a surgery, it would make sense to me that that would be something that would be reasonable to do. But that's something that's certainly under investigation, but I wouldn't say that there's proof of that quite yet, but certainly under investigation. And if you had a radiation oncologist and a urologist who were particularly cutting edge who wanted to do that, I think that would be a very reasonable thing to try.
Okay, great. And now, can cancer come back from a radiation treatment?
So yes, cancer can come back from radiation treatment in the sense that, you know, radiation, every time you give a treatment, theoretically it kills a fraction of the cancer cells there. But if you have a couple of cells left behind after all of your radiation has been delivered, those cells can subsequently grow afterwards. So yes, it can. Now, is it likely? It depends on how radiosensitive or radioresistant your prostate cancer is. Typically, prostate cancer is reasonably radiosensitive, but it can happen.
Okay, and is there a SpaceOAR product that's used to insert between the bladder and the prostate to help reduce side effects to the bladder?
Yeah, you know, the answer is no, because the prostate, I think, is too intimately attached to the bladder. Whereas between the prostate and the rectum, there's what's called a potential space that you can inject the spacer into. That would be much more difficult to do up and over the prostate, between the prostate and the bladder.
And can you comment on focal laser ablation as a treatment option, since we're talking about radiation?
Yeah, focal laser ablation, you know, maybe Dr. Williams has a little more experience with that than I do. You know, it's a little outside of our subject matter today. I am a little skeptical of any focal treatment that doesn't treat the entire gland because I don't think that's a cancer therapy. Now, if you're doing a focal laser ablation to temporize things, to make your PSA go down and wait until you need a true cancer therapy, then that seems like a reasonable thing to do. Or if you're treating a local recurrence of prostate cancer and there are no other options and you want to do it on a trial, that would be reasonable to me. But I don't consider focal laser ablation, cryotherapy, or any of the other focal treatments to be true cancer treatment.
Okay, and then if the cancer comes back after radiation, can the prostate still be removed?
So yes, technically it can still be removed, but it may be very difficult to do that. And the problem is radiation causes the prostate to adhere to tissue nearby, like the rectum, for example, and it makes dissecting the prostate away from those tissues much more difficult. So there are doing a prostatectomy after radiation is very risky. Is it impossible? I'm told it's not impossible, but it is risky. Now, Will SpaceOAR, for example, potentially increase the feasibility of a post-radiation prostatectomy? I don't know the answer to that. I think SpaceOAR has only been around for a couple years, so maybe we'll start seeing more case series and reports of a prostatectomy after SpaceOAR protected radiation treatment. But for now, it's possible, but it's very difficult and with a high risk factor.
Then as the last question for now, Dr. Yu, and I'm going to save some of these erectile dysfunction questions that are coming in for Dr. Williams, but Dr. Yu, could you elaborate on, you had talked about how SpaceOAR is capable of being able to, I guess it was a surprise, if I'm hearing you correctly, that if it was able to reduce side effects involving incontinence. Can you elaborate on that?
Yeah, so when you give radiation to the prostate, there's a distribution of that radiation where you have the center of the beams at the prostate, but how the radiation outside of the prostate is kind of spread out is a little bit of the art of radiation therapy. When you have a target you're trying to avoid that's immediately behind the prostate, then more of your radiation actually spills laterally to the sides. And that turns out to be into what's called the pelvic floor. My hypothesis is that with SpaceOAR, you can be more conformal with the radiation. You don't have to work as hard to try and spill the radiation around the sides. And what that allows is less high dose to go laterally into the pelvic wall. And I think that all of that helps support your pelvis and improves your urinary control. The other thing is what I mentioned before, if you have frequent bowel movements, you're going to have frequent urination as well. Everything's connected. The next time you have a bowel movement and you need to urinate, try not to urinate and see what happens. So I think the interconnectedness of everything in the pelvis is the other reason that SpaceOAR hydrogel helped urinary symptoms as well.
Well, great. Well, thanks for the presentation, Dr. Yu. Very fascinating, and thank you for answering questions.
You're welcome.
Thank you so much for joining us. I'm going to shift over to Dr. Williams now, who's going to cover for us life after prostate cancer, recovery as a journey, to talk about erectile dysfunction solutions. Thank you for joining us, Dr. Williams.
Thank you. Is my voice coming through clear?
Yes, I can hear you.
Okay,
fine.
Make sure everyone can hear me. So I do want to welcome everyone who's attended and listened to the webinar tonight. Dr. Yu did a wonderful job. In fact, I ought to just sit back and let you look at my slides and go and give your own presentation of my slides. You did a wonderful job, and I probably even learned a few things myself. We're going to briefly talk about two of the potential side effects from having radiation therapy for prostate cancer or from having a radical prostatectomy, which is the surgical removal of the prostate. We're talking two potential side effects, which would be the leakage of urine, what we also call stress urinary incontinence, or erectile dysfunction. So we'll go through these slides, and I may spend a little more time on one slide versus another one. I may even go back a slide or two, so I may change things up a little bit. Dr. Yu's already mentioned kind of briefly with a good overview of prostate cancer, and that it's extremely common in men. It's the second most common cancer in men. But in our country, the United States, we don't have as many men die of prostate cancer, mainly because we screen for prostate cancer. A lot of other countries do not screen, or they're not as aggressive as we are. However, that being said, as Dr. Yu alluded to, there has been a decrease in prostate cancer screening in the last few years. And I won't belabor the point, but there was one organization, namely, who really did a good job in persuading our primary care physicians, the family practice, the internal medicine, the so-called gatekeepers, and really produced some evidence that wasn't very strong evidence of basically saying that men should not have prostate exams and PSAs on a yearly basis. And that really put us back many, many years. And so we're trying to catch back up. So there has been an increase in advanced disease recently. So we'll talk about incontinence first. So what are we really talking about? Well, it gets kind of confusing when you talk about incontinence. Let's break it down in two different ways, if you will, two different definitions. You can have urgency or urge incontinence, and that is more likely to be seen with what we call like overactive bladder. A lot of women, men can have it too, but it's more common in women because they've delivered children and the pelvic nerves and or muscles have been disrupted. So those are the patients who have the constant urge to go urinate. And if they don't make it on time, then they might lose their urine. That's urge incontinence. We don't really see that in prostate cancer if the prostate has been removed, but you can sometimes see a little bit of urgency and urge incontinence in those patients who have elected to have radiation, and maybe just a little bit of radiation has irritated the bladder. So we're really not here to talk about that because that's treated with medication, different pelvic floor type exercises. What we're going to talk about more today is incontinence after a radical prostatectomy, after you had your prostate removed, and when the person coughs or sneezes or laughs, they tend to leak urine. But we can talk about both. I'll interchange both because Dr. You talked about radiation. So I've got to at least mention and keep touching a little bit on the urge incontinence, but the slides I present won't really allude to that as much. Now, how often does incontinence happen on either side, radiation or radical prostatectomy? Well, luckily not that often, but we do see it. But luckily, again, it only lasts for about 6 months to a year. In fact, most evidence shows that somewhere between 6 months and 1 year, whatever degree of leakage you have, more than likely you're not going to get worse. And it's also quite likely that you might continue to improve a little bit. But 6 months to 1 year is kind of the baseline, if you will. Now, how common is it? Well, on this slide, it shows that it's at least 1 in 10. And I probably think it might be a little bit higher with radical prostatectomy. So this slide is looking, if you see on the first sentence where it says 1 in 10 men have persistent SUI. Well, SUI is a real sexy way of saying stress urinary incontinence. So that is the type of leakage, again, that men have after they've had their prostate removed, and they leak urine when they cough, sneeze, or they squat down, or they go back on their golf swing, or whatever their hobby is. Surprisingly, that statistic is a little bit more in favor, or a little bit less, if you will, if you choose to have radiation therapy. Urgency and urge incontinence is not quite as severe after radiation therapy compared to stress incontinence. Now, obviously, there's a lot of different ways that you can deal with this, and I'm sure, and unfortunately for you, many of you who have logged in and are watching this webinar and listening to it, you're going to see a lot of these slides that you know very well. Adult diapers, all the pads. You can also use a penile clamp, which is in the bottom picture of the cartoon. And essentially, that's a clamp that goes above and below the penis with some foam to gently clamp the penis, trying to help prevent some of that leakage of urine come out. Obviously, we will go over some dietary modifications too. Obviously, if you're one of those type of people that enjoy drinking a lot of caffeine, several cups of coffee during the day, or maybe you take diuretics for your blood pressure like Lasix or hydrochlorothiazide, well, you're going to produce more urine during the day. And so your leakage might actually be worse. So those are questions that we would go through and try to get that information from you, during some of the initial visits to try to look at some of your intake of fluid, things you're doing daily that we might could help modify. Obviously, pelvic floor exercises, also called Kegel exercises, which essentially the tightening of the pelvic muscles. If you don't know how to do that very well, most urology departments will have a therapist who can help teach men to do that better. Well, another option is if what I've presented so far is not good enough, you can do a bolting agent whereby we, in the clinic or in the operating room, go in and inject a type of medicine that is injected into the penis, into the urethra, into the walls of the tissue, which basically is like, if you'd imagine just filling it up with a ton of cotton balls. It basically bulks up the tissue, trying to make it squeeze in the middle to reduce leakage. But we're not going to get 100% with that. Another option, which is presented in the bottom right-hand corner of the slide, is a sling, a polypropylene mesh. Now, we've been doing mesh repairs, or slings, if you will, on women for many, many years with unbelievable success, great success. But it took a while to really get the sling correct for men, simply because the leakage that women have when they cough or sneeze, the reality of it was the reason they were having it was a little bit different than it was for men. And so we tried to imitate the exact type of sling from the get-go in men, and it didn't work so well. But many, many years ago, we figured the right way to do it. And so we have the sling now, which essentially, it doesn't wrap around the urethra, which is the water channel that takes the urine from the bladder outside. But we kind of compress, not to the point that we make it so tight that we're cutting off the urinary stream, but we compress the urethra and advance it back into the body 1 or 2 centimeters. And that little bit of support usually will get guys 100% dry or very close to it. Now, obviously, if someone's leaking really, really severely, maybe 7, 8 pads, diapers per day, this may not be the best option. But for someone who's leaking 1, 2, perhaps 3 pads per day, this is a wonderful operation. And as I would never promise a home run, nor would any surgeon promise a home run, in that case, though, I'm shooting for a home run. I'm trying to get that gentleman completely dry. As I mentioned, for those who are leaking many more pads or diapers per day, the sling may not be enough for that person. So in this cartoon you see on the right, there's a cuff, and you can see where it says CUFF. Well, that is a balloon cuff that we surgically place around the urethra, not just on top of it to compress it, but it's 360 degrees around, and it is connected to a balloon you can see at the top that has water in it, and that's connected to a pump that we place surgically in the scrotum between the testicles. And you can't see any of this. None of it's hanging outside the body. It's all internal. And essentially what happens is the bladder fills up like it normally would. The guy has the same sensation that his bladder's full, but he can't urinate because that balloon cuff is inflated with water. It's physically squeezing the urethra, the urinary channel. And so when he has an urge to urinate like any other person would, he simply reaches between his testicles. He finds that little pump and he squeezes it one time, and that deflates the balloon cuff and sends the fluid back into that balloon reservoir. And then by its own mechanism, it automatically refills. There's nothing you have to press to reactivate it. It does it back and forth. It's a self-contained system. So that's a wonderful operation to do for someone who has a lot more leakage. The important thing is to remember is that, number one, luckily, most guys who choose radiation therapy or surgery for their prostate cancer don't have an enormous amount of leakage. Okay, that's the first thing to remember. You might have some in the first 6 months. That's very common with radiation or surgery. But as I said earlier, in the first 6 to 12 months, usually that resolves. But once you get to that point, whatever amount of leakage you have typically is where you're going to be. And that's really when you need to start talking to your urologist about long-term treatment. So in those first 6 months, if you're having a little bit of urgency from the radiation, sure, there's some medication you can take. You need to talk to your urologist. If you're having a little bit of leakage when you cough and sneeze, there's some things we could do. But it's really at that 6 months to 1 year period after radiation or surgery that is probably where you're going to be the rest of your life. And that is where we have to start making an assessment of what's the best option for that particular person at that time. Well, I mentioned early that the 2 side effects were stress incontinence or urge incontinence with radiation therapy. The second one is erectile dysfunction, or we also call impotence. Now, it's interesting, if you want to talk about erectile dysfunction, what's the exact definition? Well, it's different for every single person. I mean, one guy may say, well, I can't get an erection very well for penetration for intercourse. Someone else may be able to get a good erection, but he can't maintain it long enough. Or in many cases, the gentleman has both of the issues. So there's a spectrum of what a patient will say is, erectile dysfunction. And basically everything I just mentioned is a form of erectile dysfunction that we need to address. Luckily, again, it's not really, really common to have complete inability to have an erection. But that being said, the statistics are very clear that 50% of men who have their prostate removed will have some degree of erectile dysfunction. Now, that doesn't mean they can't have any erections, but they're going to have some degree, but it may get better or it may get worse. It may take as long as 2 years, as the slide shows, to regain sexual function. You can do penile rehab. Now, what that essentially is using a vacuum erect device. It's a cylinder that you place over the penis, and it creates a vacuum, either electronically or with a hand pump. And before you place the cylinder over the penis, you preload a really thick band, almost like a thick rubber band on the end of the cylinder. And so before you release the vacuum, the penis is erect, and just before you turn the vacuum off, you slip the band off, and it holds blood into the penis. Now, the great thing about the vacuum pump is, number one, the way I just described it is a way to maintain an erection because the band will keep the blood in the penis. But for daily rehab, you don't have to place the ring necessarily. You can just literally inflate or activate the vacuum erect device so the guy gets erections every single day. The key to penile rehab is that the guy gets an erection almost every day. You've got to keep fresh blood flow into the penis. It's like lifting weights. You can't expect to go lift a 50-pound dumbbell if you haven't lifted one in 3 or 4 years. You've got to work your way up. You've got to continue that resistance training. So it's the same thing with erections. Penile rehab is just a fancy way of saying the guy has to have an erection every day or so in some form to maintain erections. So I've alluded to some of the options here. So I'm going to move from the right to the left on the written information. So penile injection therapy has been around for a long, long time. Now, I know the thought of needles and penises may not sound very appealing to most people, but it's really a great therapy. And the penis itself, deep inside, does not have any nerves, only the skin. So once you take this little bitty needle, and it's like the size of a needle that someone would inject for insulin for diabetes. It's a real small needle. It doesn't have to go very deep. You inject the medication into the penis, and it typically gives the guy an erection about 10 or 15 minutes later and can last anywhere between 10, 15, or 20 minutes. Another option that's listed there is urethral suppositories. Now, that's kind of fallen out of vogue over the last 10 to 15 years, but it's essentially a little pellet that you place inside the urethra to the end, and it dissolves. But there's a lot of side effects to it, a lot of stinging, a lot of burning. It doesn't work very well. And honestly, I've prescribed it probably twice in 14 years because there's so many other methods available. There's a mention at the bottom of that right of penile implants. I'm going to save that one because that's going to be the next slide. In the middle is the vacuum pumps, which I've already spoken about. In the picture to the top left, there's a picture that kind of shows that. It shows him having the cylinder over the penis, and then in the picture, he's got a band on the base of the penis. To the left is the oral medication. So this gets into Viagra, Cialis, Levitra, those medications. They've been around for a long, long time. And what they do essentially, each of them have their own chemical formula and patent, but all they do is they increase the blood flow into the penis. That's all they do. It's a great invention. It really changed everything about erectile dysfunction for men because all we had was injection therapy, surgery, or the suppositories, or the vacuum pump. The medications changed the world, as you know. The problem is the medications, they just don't work for everyone. Or, many of you know who are listening, you took it, 5 years ago, they used to work great. Now they don't work, doc. What's wrong? Well, the medicines just don't keep working for everybody. Sometimes we'll try a different one. But usually we find that once one quits working for whatever reason, typically another one's not going to work. Doesn't mean we won't try it, but probably it's not going to work. So penile implantation is a surgical procedure. Now, obviously, you've had erectile dysfunction. You're suffering from it because of radiation or radical prostatectomy for your prostate cancer. You're a couple years out, let's just say. Well, obviously, you're going to try Viagra, Cialis, Levitra. You're going to try medications first. You may try those medications along with a vacuum erect device, the pump. So we don't naturally go straight to a penile prosthesis. That's not a first line. But by the same token, I don't want to wait 5 to 6 years where you're miserable, you have no sex life, and you've tried and exhausted every single thing on the market, including God knows what you found online or some website that was a waste of your time and money. So we're pretty aggressive for those of us who do reconstructive surgery. We're pretty aggressive with those patients, and we keep you close to our office, close, and we don't let you go off for 6, 9 months away from our office. We're really going to work with you very quickly in the months after your radiation or your surgery for your penile rehab. And if you're not doing well and you're a good candidate for the implant, then we're going to be pretty aggressively and start showing you videos on this surgery and talk to you very seriously about a penile implantation. The surgery only takes about 20 or 30 minutes if it's done by someone who does a lot of these. It feels
Dr.
natural.
Williams, I'm sorry to interrupt, but can you speak up just a little bit?
Yes, I can. The prosthesis feels extremely natural. You can't see any of it. The beautiful thing about it, among other things, unlike, say, Viagra, Cialis, Levitra, those medications, you've kind of got to prepare for it, right? You've got to know that tonight's the night, something's going to happen. You've got to take the pill. It has to digest through your stomach, get in your bloodstream, and maybe it doesn't work. So this, you can pump anytime you want to. You can inflate, deflate 1,000 times a day if you want to. It doesn't make a difference. Remember, having an orgasm, having an ejaculation, it correlates with an erection, but they're not one and the same. So once a guy has ejaculation, there is a time that the penis will go soft, which is called flaccid. And there's a time, a refractory period, before the guy can have another erection. Okay. But as we all know, you don't have to ejaculate every time you have an erection. So that's all the penile implant does. It's the same thing as taking Viagra. It's just a way for you to have an erection. It doesn't make the orgasm better. It doesn't make it stronger. It's just simply a way to have an erection. The surgery, like I said, takes about 20 or 30 minutes. The incision is made either above the penis or below the penis. It's surgeon preference, and that's a whole nother discussion. It's usually performed as an outpatient, not necessarily. Some surgeons like to keep the patient in maybe for one night. I think most of us like to send the patients home the same night because there's really nothing to do for them that day or that night. The bottom line is really getting to the root of the issue. If you're one of those guys that have been suffering for erectile dysfunction for a long, long time, you've waited too long. This is something you really have got to get to a urologist if you don't have one and really get the issue addressed, because the longer you go without good erections, the more damage is done. A study was done not too terribly long ago where I won't belabor the research of it, but they basically looked at the vessels, the blood vessels in the penis, and kind of compared them to the blood vessels that go to your heart, the coronary vessels. And lo and behold, the same disease processes that we see that happens in coronary artery disease happens in the penis. And we think it's because of poor oxygenation, scar tissue, atherosclerosis, the plaques. We see the same disease processes occur in the penis as it does in the heart. The only difference is in the heart, you get the side effect of a heart attack. In the penis, you get erectile dysfunction, and it continues to be a problem as you go through life. So we really want to be aggressive with finding therapies and treatment for you on this. So to kind of summarize the first question, how long does it take to achieve bladder control after radiation or a radical prostatectomy? Well, I said it. You need to wait for about 6 months because there's going to be some side effects. There can be some degree of leakage. But at that 6 months, 12-month period, you've waited long enough. don't be quiet. You need to get the issue addressed, bring it up, and talk about it. Why do some men recover their erections after surgery radiation, some don't? Well, this is a really good take-home paragraph. You got to be honest and look at yourself. Well, did you have erectile dysfunction before you had treatment? Do you have high blood pressure? Do you have diabetes? Do you smoke, or did you ever smoke? Are you morbidly obese? Do you have an active exercise and physical life? The other thing is, which is really sad too, is that some of the medications used to treat these disease processes, like the statins, all the medications that help to lower your cholesterol. Well, high cholesterol can cause erectile dysfunction, but so can the medications. And some of the medications you take for your blood pressure, well, I'm sorry, but some of those medications also add erectile dysfunction problems. So it's almost like you can't win for losing. So the slide here says that 30% of men suffer from erectile dysfunction 1 year after prostate cancer. I don't agree with that. It's much higher. As I said early on, it's about 50% or more have some degree of erectile dysfunction. Are penile implants covered by insurance? Yes, they are. They are. There's always things you have to talk to with your surgeon, with the financial advisors at the surgeon's office in regards to deductibles, copay, secondary insurance plans. That's always an issue that somebody at the office of the urologist can address for you. But yes, insurance most of the time does cover the penile implants and the urinary sphincters and the sling for incontinence. I'll leave this slide up for a few seconds, but all of you who are attending the webinar will have access to the entire presentation that you can come back to later. So a lot of these websites are sites that you can access later and look them up and find further information. The take-home message I really want to make clear on this is, number one, you're not alone. Some of you may have both of these issues. You have incontinence and you have erectile dysfunction. And the take-home really is that you're not alone and that you need to get this looked at, because this is not one of the things that you just have to say, well, I chose surgery or I chose radiation and I'm unfortunate and, they told me I might have some problems. And I guess that's just how, that's the cards that were dealt with me. Well, that's not true. Okay. You don't need to think that. You can seek medical treatment, but it might require surgery. But don't just take it, okay? Talk about it, talk to your family doctor, talk to your urologist, and do everything you can to seek some sort of evaluation and therapy and hopefully get some treatment to have you get to a better quality of life.
Thank you, Dr. Williams. Just have a few questions for you that's coming in from the audience. Patient writes that he's 3.5 years removed from a radical prostatectomy and still struggles with ED, taking Viagra and Cialis. What are your thoughts on injection therapy, or what would you recommend to help get him back in the game?
So the question was, with a gentleman who is about 3.5 years after radical prostatectomy, having erectile dysfunction, and looks as though he has tried and failed both Viagra and Cialis. So yes, I think injection therapy is a good option to try. Another one would be that if he's getting some degree of erections with the medications by mouth, then I think trying those medications along with the vacuum device is a good option. And so is Trimix. Those are both lateral moves. I can't say one's better than the other. Unless the Viagra and Cialis is just absolutely not helping him at all, then I think the penile injection therapy is a wonderful option. I will say this, at least in my office, and for those who do a lot of reconstructive surgery for erectile dysfunction, we offer what's called a penile duplex study. That's just a real fancy way of saying we basically give you a small injection of medication in the penis in the office, and then we take an ultrasound device and we measure the blood flow going into the penis and out of the penis, and we measure the size of the blood vessels. And using the ultrasound, we really have changed things quickly. We've really been able to diagnose exactly what that guy's problem is, and not just throw him into an overall category A, B, C, or D, but we actually find what his problem is and help direct him on the best options. And so a lot of times I can do that, and I can avoid months and months of wasted time, wasted energy, and save the guy a lot of money and frustration, and really get down to the point. He may not like the options I give him, but I can at least tell him exactly what's going on and really try to set things forward in motion for him a lot quicker and save a lot of frustration. So that's one thing you want your urologist to be able to do, is ask them if they offer a penile ultrasound or a penile duplex study.
Great. Thanks for that answer. Another patient writes, nobody told me to use the vacuum pump daily. How long should the vacuum pump be used? 10 minutes, 15 minutes? How long would you recommend?
Yeah, it's a good question. The question was, how long should you use the vacuum pump? There really is no right or wrong answer. You can find a ton of different research papers out there of different people trying different things. No one has really ever come up with the perfect thing, and they never will. No one's ever going to be able to say you have to do it twice a week, 3 times. But let's be honest with you. If I want to, increase the size of my biceps, if I go back to that dumbbell, the 50-pound dumbbell example, if I lift dumbbells once a week versus 7 days a week, you know which one's going to give you the better benefit. So doing the vacuum erect device, if it's really an important part of my life of maintaining and regaining my sexual life, my sexual health, if that's an important thing to me, then I'm going to do everything I can. So I'm going to use the vacuum erect device daily or every day. And how long do you leave it, the vacuum on? Nobody has a clear answer on that either. But obviously just a minute or two is not going to do it. You want to keep good blood flow. And remember, the tissue is it's a spongy tissue that's inside the penis, full of all these little nooks and crannies that need to increase and expand with blood in order to give the erection. So you want to expand all those little nooks and crannies, all those little channels. So personally, I think you should leave the vacuum erect device, in play for at least 5 or 10 minutes to really get a good feel of all those little areas. But honestly, nobody really knows the right answer to that.
And as you said, just like lifting weights, that should be done daily in order to build up strength and endurance.
If I had the problem with erections, I would really do the vacuum pump probably daily or every other day. I mean, I would do it as much as I could, because the more you do it, the more you're going to expand those channels and get fresh, oxygenated blood, and you're going to expand those channels. You're going to have better erections that way.
Great. And do you have thoughts on shockwave therapy?
That's a good question. Shockwave therapy, there's several on the market. The famous one that's really out, the name that catches everyone's attention is GainsWave. And there's a couple even in Dallas, Texas. We don't offer it here in Tyler, mainly because there's no proven benefit in it. This year at the Sexual Medicine Society meeting, the national meeting, which will be held in Nashville in about a month, there'll be more information as more people are beginning to use it. But the patients I have dealt with, and that's 5 so far that have had it done, had no benefit in it whatsoever. We don't even really understand how the shockwave therapy works, but the thought process is that somehow it's causing a controlled injury or controlled damage to the erectile tissue, and then somehow it's increasing the production of blood vessels, new healthy blood vessels. And that's the theory, but no one's proven that ever. And in fact, the only studies that have been worthwhile, that have been remotely shown any benefit, were those that were done with a machine that you can't tolerate the shockwave unless you're sound asleep. It's basically the same machine that we kind of use on kidney stones. So the ones that you go into a doctor's office and they take a magic wand and place it on the penis and shockwave the penis, the studies so far have shown that that is not powerful enough to have any true and durable effect. So we don't know for sure, but so far I've been really underimpressed with it.
Okay, and then the pump that you're talking about, Dr. Williams, patient asked, where's the best place to learn more about that or to get it? Is it edcure.org and fixedincontinence.com? Where would you say they should go?
I don't have a specific website. Here in Tyler, and a lot of patients can find this out if they'll ask their urologist. A lot of urologists, surprisingly, will partner up with a pharmacy. I know that sounds really strange, but a lot of times the urologist will have a pharmacist who has a license to compound medications, like for the penile injection therapy. And a lot of times that pharmacist will kind of make it their niche, whereby they will provide catalogs and magazines in the pharmacy. I know it sounds crazy, but a lot of times they will provide that therapy and that evaluation to the patients at the pharmacy. Some urologists will have a nurse practitioner or PA that does a lot of that information in their office too. But there's a lot of websites, and one of them is ed.cure, that has good information on getting a vacuum erect device. You can order them online, but I've had many times where patients they don't like the cost of the ones they find that are reputable and durable, and still go online to some site and get one for $30 or $40, and they come back and say it didn't work or it didn't last that long. So they don't cost thousands of dollars, but the ones that you just go to some cheap site online that's $30, $40, they may not work very well. So go to like ed.cure, any website, and let that help direct them.
Great, thank you. And is erectile dysfunction normal or a regular common occurrence after radiation, or how common is it?
That's an excellent question. I get that all the time. So how common is erectile dysfunction after radiation therapy? Well, let me answer it in two ways. It's not common and it is common. So the nerves that allow a man to have erections, unfortunately, are on either side of the prostate. They're almost invested into the capsule, if you will, of the prostate. And so when you get radiation therapy, obviously we're radiating the prostate. So the chance of erectile dysfunction is fairly low in the first few years. In other words, we don't make it much worse with radiation. That being said, though, as months and years go by, that guy will begin to have more erectile dysfunction because the nerves eventually will get the side effects of the radiation. So early on, they don't have as much erectile dysfunction as, say, someone who has the prostate removed surgically for prostate cancer. But eventually, as the years go by, they will. And the prevalence of erectile dysfunction, or the rate or the risk of erectile dysfunction with radiation patients at 3, 4, maybe 5 years does reach the same level as the risk of someone who has the prostate removed. It just happens a few years later.
Okay. I have one more question for you, Dr. Williams. I know that we're over past 7:30, but what is the percentage of implants that end up failing or breaking? Is there much data on that?
And so the question is, what's the rate of failure of implants or breaking or something going wrong? The take-home message always has been that about 85% of penile implants are still working well at a decade. And that's pretty phenomenal. That's better than the data that you can get with most people who get total knee implants or total hip. I'm not saying that their hip or knee implant breaks down, but there's a lot of wear and tear, at 10 years on those people who get a total knee or a total hip implant, whereas you don't see the same failure rate in penile implant. So I'd say an easy number would be 85% at 10 years of penile implants are still working well.
Great. Thank you, Dr. Williams. And for those who had questions that we couldn't get to, we'll be sure to forward to the doctors to answer and see if we can get some of the answers out to some of our participants. I'd like to thank our sponsor again, Boston Scientific, and their website, edcure.org and fixedincontinence.com. And of course, I'd like to thank SpaceOr. I'd like to thank our doctors, Dr. Yu and Dr. Williams. Thank you for fascinating presentations. And I also would like to cover a couple of programs that we have going on at Zero to get more involved in the prostate cancer cause. Coming up in February, late this winter, we have our annual Zero Prostate Cancer Summit from February 23rd to the 25th in Washington, D.C. We're talking about access to care issues and being able to minimize side effects. In order to be able to do that, we need to make sure that places like Medicare cover all of these different tools and medications that are needed in order to be able to not only reduce and minimize and eliminate side effects, but also to treat prostate cancer. So it's critical to bring in advocates from around the country to talk to their elected officials to make prostate cancer a federal priority and to be able to fight to increase prostate cancer research funding. And we'd love to have all of our participants find out more about that and join us at our Zero Prostate Cancer Summit in 2020. Some other programs that you should consider is our 0360 program. It's a comprehensive patient navigator program that we provide free to patients. We are able to give each patient a trained case manager who can help them find copay and other medical debt to be able to get enrolled in Social Security disability if you qualify, if the insurance company has turned you down for your treatment. These are all things that our patient navigator can help you all for free. We have a mentor program that's a peer-to-peer program that we match you up with a prostate cancer survivor or a patient that has a similar experience to you. If you're a new patient or new to Zero, we'll match you up so you can use your mentor as a sounding board or someone to get advice from, someone who can help you with their experience, strength, and hope through their journey with a wealth of insights to share. And we also have our program, Zero Connect, which is a private, closed Facebook group for prostate cancer patients, survivors, caregivers, and family members, loved ones, and friends to be able to ask questions and come together to share their stories and share their experience, strength, and hope around their prostate cancer journey. And finally, the last couple of programs that I want to remind everybody about is that we have our Zero Prostate Cancer Drive. So if you're a prostate cancer patient that lives currently in New York, Pennsylvania, and Texas, we have a transportation program that removes the barriers to care so we can get patients the transportation they need to be able to see the doctor. And we utilize ride-sharing technology to be able to lower the costs and get you to your doctor appointment for free, so you can stay in your fight and have a long, happy, healthy life after prostate cancer. And finally, if you want to know more about prostate cancer testing, we have a database online at zerocancer.org that you can access to be able to get find out where to go for free screening, and we have hundreds of places across the country as part of that database to be able to find where you can get tested and screened for prostate cancer. It's important because 99% survive when prostate cancer is caught early. And once again, thank you for everyone for participating and asking questions. And thanks again to both of our speakers, Dr. Yu and Dr. Williams. Once again, my name is Jamie Burst. I'm the president and CEO at Zero, the End of Prostate Cancer. And you can reach me here at this email, phone number, or on Twitter at any time. And we will do our best to be able to help all of our patients and families that need support. Thank you again for joining us tonight. And good night. Thank you.
This conference